Welcome to everyone joining the webinar. We'll give people a couple more minutes to log in and then we'll get started. Once again, welcome to everyone joining. We'll give people another minute or so and then we'll get started. All right, well, good morning and welcome to everyone joining this webinar. Welcome once again to this discussion on IPV therapy for adult respiratory care, where we're going to go into the background of airway clearance and bronchial hygiene therapy and review a few case studies on patients receiving IPV therapy. My name is Chelsea Lee and I'll be moderating this webinar today. Before we begin, just keep in mind that you can ask a question at any point during the webinar. Just click on the Q&A button at the bottom of your screen and type in your question. We will answer those as time allows at the end of the webinar. If you have any technical difficulties, you can go ahead and type it in the chat box. This course is accredited by the AARC as well as the California Board of Nursing for 1 contact hour. To receive your certificate, fill out the evaluation form that will pop up at the end of the webinar. If you happen to miss the link the first time, you will also receive a link tomorrow in your follow-up email. Just complete the form and include your license number if you have one, and you will then receive your certificate by email, but just be sure to complete the evaluation to receive your certificate. Now, I'm very happy to introduce our speaker for today, Andrew Klein. Andy started his respiratory therapy career in December 2003 and is currently the Adult Clinical Education Coordinator and an Assistant Professor in the Respiratory Care Division of the Department of Cardiopulmonary Sciences at Rush University Medical Center in Chicago, Illinois. He has been a nationally recognized preceptor of the AARC since 2017 and is a member of the Mechanical Ventilation Domain Task Force at the American College of Chest Physicians. Andy was recognized as a Distinguished Chest Educator in 2021, 22, and 23, and was named a Fellow of the American College of Chest Physicians in 2022, as well as a Fellow of the AARC in 2023. He has lectured locally, regionally, and nationally, and has provided education for the ISRC, AARC, CHEST, and the Society of Critical Care Medicine. So welcome, Andy. I'll let you take it over from here. Oh, sorry, Andy. I think you're muted on us.
my fault. Sorry about that. Thank you so much, Chelsea and Centec team for everything that you guys have done to set this up. We had a lot of behind the scenes conversations, and I know you guys have worked hard to make this happen, and so I appreciate the opportunity. And thank you to my friend Tom Russell for the introduction to get this set up. So I'll get started. I have no conflicts of interest that relate to this lecture, and due to the content of the lecture, we're going to talk about multiple devices from multiple different companies, and I just want to make sure that I mention that I have no bias or preference towards any specific device or any specific company that we're going to talk about today. So objectives to get us started, we want to try to understand the benefits and limitations of some of the current methods we use for secretion clearance, lung recruitment, hyperinflation, resolution of air trapping, those types of things that we run into clinically. Understand how IPV therapy works specifically, and how it targets and improves gas exchange abnormalities, and to identify some patients and maybe diagnoses that may specifically benefit from IPV therapy. So to get us started, bronchial hygiene, and this is just one of probably 1,000 definitions that people have seen, but this is just one that I liked that I thought encompassed everything. So it's a broad term to describe various airway clearance techniques, such as chest physiotherapy, which usually consists of postural drainage and some form of percussion or vibration, followed by coughing and suctioning. Breathing exercises such as huff coughing, diaphragmatic breathing, usually used for spontaneously breathing patients, and then manual hyperventilation, which we typically would use in intubated patients. And why we do bronchial hygiene therapy typically is to improve the clearance of secretions. So, sometimes that just means that we have extra normal secretions, and sometimes that means we have special kinds of secretions that are causing us issues. So, either way, we want to decrease airway obstruction, enhance ventilation and gas exchange. That's our ultimate purpose here. And this applies to adults and children, as well as both acute and chronic issues that cause this. Our mission today in the next hour is to focus more on the adult population. That's more my wheelhouse. Although I do have a lot of colleagues and I do have a lot of conversations about the bronchial hygiene that's done in children, so I'm aware that it's there, but we'll focus mostly on adults today. So in 1986, so rewinding a bit, Philip J. Cole described in a paper this what he called the vicious circle of mucus production and bronchial inflammation that's a result of that. So we have chronic secretion retention and inflammation, which decreases lung function and causes more mucus to be produced. And then the more that's produced, the more we retain, then we accumulate those. Eventually, we get some airway occlusion that's a result of that. Then the mucus starts to dry out, and then we get mucus plugging. That dramatically increases the risk to the patient's health, as I'm sure everyone knows. And then this creates this chronic inflammatory disease, and on and on and on. So when we think about bronchial hygiene therapy and the stuff that goes into performing this, it's really most effective in conditions that have excessive sputum production. These are the ones that have been more researched. These are the ones that have, that we've pretty much universally accepted that bronchial hygiene is going to be effective in. So acute illness with copious secretions, acute respiratory failure with clinical signs of retained secretions. So really what we're looking at here is some evidence that whatever we're seeing clinically is a result of secretions, and that secretions are playing a role in the diminished capacity that the patient has. Perhaps some lobar atelectasis that's caused by this, and then all of this leads to eventually ventilation and or perfusion abnormalities, which are a direct result of these lung infiltrates or the consolidation created by them. So some contraindications. If we think about this, it really depends on what type of therapy. We're going to talk about several different ones that are available to us. But in general, we should be aware of any sort of trauma, especially where we're going to apply the therapy. So for example, if I have some sort of chest trauma, if I have broken ribs, for example, and I'm going to put a vest on someone, that may be a contraindication for that therapy, but maybe not for vibratory PEP therapy. So again, these are specific to the therapy that I'm considering using. And then in general, elevated ICP is a contraindication for any therapy that we think about doing, as well as untreated tension pneumothorax, unstable fractures of the neck, since no matter what we're doing, it's probably going to vibrate the patient's body in some way. And then hemodynamic instability is another one of those. It's pretty much a contraindication for everything that we do. So we have some acute conditions as well as the chronic ones that were mentioned. So COPD, especially in an exacerbation where there's excess secretion production. But if we think about just normal COPD, we wouldn't just do bronchial hygiene therapy because the patient has COPD, according to the evidence. Pneumonia, another one that I think we've all probably had physicians, and if there's any physicians on the call, I think they probably have ordered some if the patient has pneumonia, especially if it looks like a bad pneumonia on the x-ray. But if there's not clinically significant secretion production, and if there's not clinically significant evidence of mucus plugging, then we may not get a benefit from bronchial hygiene therapy. And then uncomplicated asthma is another one. Sure, we're going to get secretions with asthma at times, but if the secretions aren't the problem, then simply because they have asthma is probably not a wise use of the bronchial hygiene therapy. So we talked about some chronic conditions we briefly mentioned, and we do have some data to support the fact that bronchial hygiene in general is effective in diseases like cystic fibrosis and bronchiectasis, and sometimes chronic bronchitis, again, depending on the type of secretions, the amount of secretions. But in general, if you have cystic fibrosis or bronchiectasis, there's some evidence to support using bronchial hygiene just in general. So the most well-documented preventative techniques are body positioning and patient mobilization. So if your patient's able to get up and move around, that's what they should do. And that is going to be, just getting your body doing what it's supposed to do. In the post-op population, especially, we are trying to get them up as soon as it is safe. And part of that is because of the lung expansion and the secretion control that we want to get out in front of. And then postural drainage exercise and chest physiotherapy. Again, chest physiotherapy is not necessarily limited to just hitting them with your hands like we all did when we were in our early stages of our career years ago. There's a lot of technology out there now that we can utilize where we don't have to necessarily do that for all our patients. And but the chest physiotherapy, along with postural drainage and exercise, has shown to be effective in maintaining lung function in cystic fibrosis patients. All right, so lung recruitment. We mentioned that might be something that's a consideration for us along with our bronchial hygiene. So just to bring everybody to the same definition so that we share a definition here, simply recruitment to me is opening collapsed alveolar units. Why they're collapsed is less important than the fact that they are collapsed and we need to open them back up. So how do we do that? We typically add pressure to the system, and that additional pressure, along with tidal breathing, accumulates in the functional alveolus and then transfers via the connecting channels to the adjacent collapsed alveolus and hopefully open those up over several breaths and over time. And some of the adjuncts that we're going to talk about throughout this next hour are going to speak to that. So the tidal breathing, along with some extra pressure kept at a therapeutic level over time, can be recruitment maneuvers if they're on the ventilator. However, if we're talking about patients that aren't on a mechanical ventilator, we can do this with some of the equipment we're going to talk about, coupled with the tidal breathing that the patient's doing. So this is just a graphic of what I'm talking about. You can see here we have a functional alveolus that's operating normally. We have an alveolus that is collapsed and fluid filled, and then we have an alveolus here that appears to be recruitable. It just is collapsed currently. So if we add some pressure and some tidal breathing, we can utilize this functional alveolus to transfer some of that additional pressure across to this collapsed alveolus and start to open it. So when we think about inflection points, and I'm not going to make this a huge part of this talk, I just want to make sure everyone understands that anywhere below this lower inflection point that's represented here is probably collapsed alveolus that can be recruited. And so what we want to do is we want to utilize some of the things that we're going to talk about in order to hopefully, if this is part of our problem, re-expand to a functional FRC and get above this lower inflection point where the patient can function their lungs normally. All right, so that kind of concludes the intro part. Now I'm going to start to explain some of the types of therapy that are available to us in 2024. So I have a question for everyone to start with here, and I see there's a lot of people on the call, so hopefully we'll get a decent mix of information here, but I'm curious what types of therapies are available to all of you at your facility, because I know there's some variance here. So I'll give everybody a minute or two to answer this poll question. Okay. All right. Looks like a lot of people still do manual CPT. Cough assist is there. Vest is very high. PEP therapy, speaking to the handheld PEP devices. Not a lot of people using the biphasic chest cuirass. It's pretty new in the market, so I get that. And then over half the respondents use IPV therapy, so that's great. Thank you. So we have the good old postural drainage that's still around. We still I was telling Chelsea and the Centec people before we logged on that we taught the bronchial hygiene section of the equipment class to our students yesterday. And one of the things in my station was postural drainage, and I pulled up one of those, and I'm sure anybody who's been practicing any length of time, I pulled up this exact um, graphic here, and we went through all of these different positions, and I remember having to know these for the board exams and all these different things. So this is still out there. We are still using this. There is still some value to this if used in conjunction with other forms of vibration and percussion. So unfortunately, this has not gone away. We are still teaching this. We are still learning this. So it's still around, and postural drainage is still part of what we can do. We do still have manual percussion and vibration, as our poll showed. A lot of you are still doing this. Percussion just simply means the application of physical energy. So we all are still doing the cupped hands and hitting the different affected areas in an effort to move some of these secretions. And then vibration is just a rhythmic force that we can do with our hands, or during a cough that sort of vibrates and shakes the chest wall, again in an effort to move some of those secretions out to where they can be expelled with a good cough. Pros and cons of manual CPT. I mean, it's easy to do. I mean, those of us who have done it, it's not easy by the end. I know. It takes a lot out of you if you're doing it correctly. But it requires no special equipment, and it's usually pretty well tolerated by most of the people I've ever done it on. And so, but what are the cons? I mean, it's very time consuming, takes a therapist out of their, other patients for a length of time, especially if you have multiple patients in your area that you're doing this on. And it may not be as effective as some other methods we may talk about. And a lot of us have been doing this for years, the manual CPT, and, to varying degrees of success, probably. We have the vibrating PEP device, and there's a variety of these on the market. And it's just basically, in most cases, a handheld device that creates some sort of back pressure during exhalation that could improve alveolar aeration by recruiting some of our alveoli, like we talked about. And then if we add the vibratory PEP piece to this, it also combines the PEP that we talked about with some high frequency oscillations that happen at the airway opening and transmit across the airway down to the lung. And so, again, there's a variety of these on the market, as you see here. This is certainly not all of them. These are just a lot of the more common ones. And we see here, this is like the AccuPap or the Easy Pap. I can't remember which one, but there's a couple of those where you can see here we just hook these to a gas source. We have a pressure manometer, and we're breathing against the pressure created by the gas source. We have the VibraPep device, the old school flutter valve. The Aerobica device is one that we just started using at our facility. And then the Acapella device, again, I know this isn't all of them, and I don't really personally have a preference. It's just whatever your facility uses, should create the back pressure, and in the case of some of these, the vibrations that could also help to move the secretions. This is from a paper from 2017 by Van Fleet and colleagues that just sort of describes a few of those that you saw in the previous picture. and sort of how they work. And so that's there for people who haven't used some of these devices to kind of see just the technology of how each works. So pros and cons: portable, easy to use, easy to carry. If you have an ongoing secretion problem, you can carry these with you pretty easily in a purse or even a pocket. Most can be used in combination with a nebulizer. So you can sort of do multiple therapies together. Minimal clinician time is needed, because really once you do the initial explanation, you can just hook your nebulizer up and hand the device to the patient. Some cons: they can be a bit expensive. Depending on the device, they require the patient to self-motivate, because the clinician's not going to be there to tell them every time. And it's effort dependent, meaning the patient only gets out of it what they put in. If they're not breathing correctly to optimize the therapy, and if they're not picking it up off of their bedside table periodically to use it, they're not getting any benefit. So we have to think about that. High frequency chest wall oscillation, or vest therapy, as a lot of us probably know this. It consists of a two-part system, which is a variable air pulse generator. That's the machine itself. And then a non-stretchable cover of some sort. There's the vest, and then there's just sort of the chest wrap that we use. Usually covers most, if not all, of the patient's torso. And it basically takes small gas volumes through the hoses and injects them into the vest piece or the wrap piece at a fast rate and under pressure, and basically vibrates the outside of the patient's thorax. It increases airflow velocity and creates a repetitive cough-like shear force, especially if you're coughing during it, which decreases the viscosity secretions and should move them throughout the airways to get some of them to a place where you can accurately and actively cough them up. This is kind of what it looks like. A couple examples: they have upgraded some of this too. There is a newer model that has more digital, touchscreen type features. This can be used in the home or the hospital, and we use it. I saw from the poll that a lot of you all use it, so this is a pretty common thing in the bronchial hygiene universe. It's more consistent than manual percussion. Anybody who's done manual percussion knows that you cannot keep up the same level of intensity 20 minutes after you start. I don't care how good a shape you're in. It can be done with less supervision by the clinician. I know at my facility we are required, or we are highly encouraged, I suppose I should say, to stay with the patient throughout the duration of any of these treatments. However, I have worked at facilities where if we have someone on the vest that's stable, especially if we've done other therapies with them and we know they tolerate it well, we may go to an adjacent room and do some things. So I don't know what everyone's practice is, but in theory, this kind of does itself once it's properly installed on the patient, so that 10 minutes, 15 minutes, 20 minutes that your therapy is running for, you don't necessarily have to stand there next to the patient if you deem them stable and you have other things to do. So that may be a pro. Cons: obviously you need the device, which, the initial investment can be expensive, and I know some of the disposables can be expensive, and can be difficult to apply to an uncooperative patient. And again, anybody who's worked in the ICU for any length of time, you have that 280-pound, 6'2" patient that is literally just laying in the bed, not helping turn at all. And it takes 2 or 3 people to move this patient a variety of different ways to get the wrap or the vest part around them, which can be very challenging and take a lot of time in addition to the therapy itself. And so that could be a negative. IPV, or interpulmonary percussive ventilation, is basically a technique that uses a pneumatic device that delivers small bursts of gas directly into the respiratory tract at high rates. Can be delivered with a mouthpiece, a mask, in line with a ventilator circuit, or you can connect it directly to an artificial airway, which offers you a lot of flexibility. There are a couple different types here. Oscillation and lung expansion, which would be an example would be the Baxter devices here, the Valera and the Metaneb. And then on the right-hand side of this slide, you see the true IPV devices, which would be the ones from Centec. So pros and cons, we can provide positive expiratory pressure as well as oscillation, and we can provide it directly to the airways. Some devices are customizable to patient size and condition. We can give inhaled medications with this device. I'm going to talk about that in some future slides here. Can be used in virtually any clinical situation. Doesn't matter if they're intubated, trached but off the vent, not on anything at all. You can utilize this device. Again, in the con column, it requires the device, which is an initial investment for the organization. Some of the disposables can be expensive, and it requires clinician time, and in the case of true IPV, some expertise, which I'll talk about. So how do we deploy these therapies? Well, many places have some sort of protocolized bronchial hygiene situation. Some are physician driven, some are a combination of the two. This is an example of an algorithm from a protocol where we would give the patient a score on how well they are maintaining and clearing their secretions. Notice here in this top box, a diagnosis of CF or bronchiectasis is an inclusion criteria here because we know we have some data to support bronchial hygiene in that population. Again, back to the greater than 25 mLs of sputum production that we mentioned. And then this is our scoring tool, which isn't going to mean anything to most of you. But there's a variety of different ways you can score patients to determine how well they're clearing their secretions. We have the contraindications listed here. Many of these were on my contraindication list. So you can see there, this is one way to deploy it. Again, this is just lower down in the algorithm here. You can see here if their vital capacity is adequate to operate a vibratory PEP device, that could be an option here. If the patient does not have an effective cough or doesn't have a vital capacity to operate that, then we would initiate IPV therapy and we would monitor for improvements. And then we would escalate and de-escalate as the patient's condition changed and as they got better or worse. So again, if you don't have a protocolized way to deploy bronchial hygiene therapy, that's okay. I know many facilities are physician driven and they'll just say do IPV every 4 hours, something like that. And that's okay. And you can certainly use bronchial hygiene under those conditions. So talking specifically about IPV therapy, I want to get into this a little bit more because this is something that I feel was underutilized in my facility for a long time and is probably underutilized just period. And I'm going to talk about some ways that you may consider deploying IPV therapy if that's something that you have as an option. So the true IPV device, which this is just a more close-up picture of the one you saw earlier, along with the delivery device, which is called the Phasitron. So on the left-hand side of the slide here, you see the Phasitron and all the parts that go into that. I didn't have a deconstructed picture to use, but I will say that inside here, inside the back here, if you have this and you've never taken this off to look, there is a spring attached to a Venturi device in here, and that's going to come into play in a minute when I explain some of this. And then you see you have all the different hoses to connect to the front of the device to operate the Phasitron. Now you'll see here, and I'm going to talk a bit about this, you have a variety of different control knobs. And when I went over this with the students, the initial reaction is, oh my goodness, there's so many knobs, there's so much to adjust and operate. But I'll demystify this a little bit as well. So how it works and how it's different is the entrainment piece that I mentioned. So this entrainment Venturi device allows us to entrain air, which can dramatically increase the amount of flow and pressure that we're able to create. It also creates this high velocity flow here, which what it does differently is instead of if we're dealing with thick secretions or especially mucus plugging, it doesn't just send the flow down to where the mucus plug is and hit it from the front and bounce off. This high velocity from the entrainment can move the gas actually past the obstruction down to the bases of the lungs and backwards so that it is able to get behind some of these secretions and some of these plugs to actually move them from the other direction as well, towards the top or cephalad movement of the secretions, which is a different which is a different benefit for these patients. So I mentioned when we brought this into my facility, we had some initial shock, because it was so different than some of the therapies that we were using, and there was a lot more, I guess, busyness to the initial setup. So one of the things I did after the initial training is I created a setup and usage guide, which got laminated and attached to all of our IPV devices, so that the staff felt a bit more comfortable in deploying this device, instead of, well, I would grab the IPV. It seems like a great idea, but I'm not confident that I can set it up and use it correctly. One of the cons, I would say, about the IPV specifically is that because you have more control and because you can adjust pressures to a much higher level than some of the other available devices, if you don't understand how it works and you don't understand how to set things, it is possible to actually, hurt a patient with this if you're not, fully understanding how to work all these things. And so you can kind of see here, and I'm certainly not going to read through this, but you can see that I covered pretty much every piece of what a clinician would need to know that has a passing familiarity, but maybe hasn't set it up a lot. And this helped us a lot with the implementation and the confidence level of our staff to grab this device when they had a choice to grab a variety of different devices. And I think that really helped with our rollout. So what does the data say about all of this, about any of this? I can tell you that at my facility, we use the data to guide all of our practices. And if we don't have data, we try to create some, and we try to share our, sort of practices and the data behind them with anybody who asks, in an effort to try to improve some of these processes overall within the respiratory care profession, because I think we can all admit we have a lot of room to grow as a profession, and bronchial hygiene is no exception. So what does the data say about bronchial hygiene? So this is a paper from 2006 from the Journal of Critical Care by I'm gonna probably get this name completely wrong, but Serrata and colleagues, talking about the efficacy and safety of IPV specifically in obese patients with compression atelectasis from their obesity who were on ventilators. And what they found was they were able to improve PF ratio from 189 to 243 at the 3-hour mark after initiating IPV. This was statistically significant. And it was able to continue to improve up to 280 at the 24-hour mark, again, statistically significant. And they were also able to improve dynamic compliance from 30 to 35 at the 12-hour mark. And then at 24, when they remeasured, it went up further from 35 to 38. So, this showed that in that population with the atelectasis that is specific to some of these very obese patients, they were able to improve the pulmonary mechanics of these patients with simply IPV therapy, which is an interesting application, and I think something that is becoming a lot more common, that we're seeing more of these obese patients both in and out of the ICU. So this might be something to keep in mind with that patient population. 2005 in critical care, Vargas and colleagues looked at IPV and acute exacerbations of COPD in mildly acidotic states. And we can see here from the results section, 30 minutes of IPV led to a significant decrease in respiratory rate, which, when we're talking about respiratory failure in this population, that is a big indicator, is if their respiratory rate stays high and they get behind. And we were also able to increase their PO2 and decrease their CO2, which again further benefits that population that's sort of on the borderline, statistically significant. 6 out of the 17 in the control group had worsened exacerbations, but 0 out of the IPV group did. Again, statistically significant. We shortened hospital stay in the IPV group. So again, this borderline respiratory failure group that isn't quite there but heading that direction, they were able to reverse that and change the course of those patients that were headed into an exacerbation and turn them around, which is pretty exciting. This is going way back. This is from 1994. This was in the Chest Journal. Comparison of IPV and CPT. So basically comparing our old sturdy hand CPT to IPV. in the cystic fibrosis population. So Natali and colleagues looked at this and found that for the adults and adolescent with CF, there may be numerous benefits to IPV to perform their chest physiotherapy compared with percussion and postural drainage. Independence was the big thing that was cited here, in that we can do just as good a job as if you had to have someone come in and beat on your back and your chest, and you were able to have the freedom to do that yourself and to take more control of your disease process, which is a big deal in this patient population. So that was way back in 1994, so 30 years ago. They showed this, and still true today. So I think that's a big interesting benefit of IPV therapy there too. So those respiratory therapists who are on the call, and even some of the non-respiratory therapists who are familiar with respiratory therapy, the AARC, or the American Association for Respiratory Care, is our professional organization, and they are responsible for helping us to understand the best practices within the respiratory therapy profession. It's one of their many functions. And you can see here that they put a whole group of smart people together in order to come up with some what they call clinical practice guidelines, or CPGs. And they have these on a variety of things. And in the airway clearance realm, they have pharmacologic and non-pharmacologic. So non-pharmacologic would be what we're talking about here today. And these were the recommendations, and all of these are supported by low-level evidence. And the simple fact is that's really all we have is low-level evidence in the bronchial hygiene realm as it exists today. So CPT not recommended for routine treatment of uncomplicated pneumonia. And I'm going to draw your attention to a couple things after I go through these. Not recommended for routine use in patients with COPD. May be considered in patients with symptomatic secretion retention, guided by patient preference, tolerance, and effectiveness. Airway clearance therapy is not recommended for the patient who is able to cough their secretions up by themselves. Cough assistive devices may be useful in the patients if that's their only issue. Incentive spirometry not recommended for routine use in postoperative patients. That's a big one. I mean, when I first started, we did IS on everybody. It was just automatic, and we still do it. We still give them an IS. It's not going to hurt them, but it's not necessarily supported by the data as being super beneficial in most patients. Early mobility and ambulation is recommended. Again, we talked about that. Get them up. That's going to be the best thing. Get their body doing what's it's supposed to do. And then routine postoperative care, we should not be doing airway clearance therapy. Now, what I want to highlight here is these people came up with these recommendations. They used what data that they could find, and there was about 75, if I remember right, different studies that they looked at and utilized in their recommendations. What I will say is that some of these words that are attached here, routine use, routine treatment of uncomplicated pneumonia, that means that there may be a subset of patients within these bigger patient groups that may benefit. And that's what I've tried to focus on in our practice here at my hospital is let's find those patients that meet some of these subset criteria that may benefit, even though routinely these patients probably won't. So now, do we nebulize through the device or not? That seems to be a question that a lot of people have, and I'm just going to go through what we know. And so this person, Gregory Reichler, has a couple of different papers that I'm going to go through. And jet nebulization, which would just be your standard pneumatically powered nebulizer that we all use and grab out of our equipment room for every patient, versus IPV nebulization. And in conclusion, in this paper, they determined that the two techniques showed comparable lung deposition, but a large difference in particle size. And it was deemed that the IPV device was too variable and too unpredictable in its delivery of the aerosol to be recommended for use to get the drug to the lung. So again, this is sort of one of those things where it's like, okay, we're talking about two different things here. We're talking about delivering medication, and we're talking about the actual therapy. Doesn't mean the therapy won't be effective. It just means there may be a better way to deliver the medication that goes with the therapy. This is another one. This is out of the Journal of Aerosol Medicine. Again, Dr. Reichler was in this group as well. This was from 2006. And excerpts from his conclusions were: we highlight that IPV used as a nebulizer delivered a much lower dose of amikacin, which was the antibiotic that they were using in this study, and that its drug output was lower when compared with standard aerosol delivery, which they looked at just the regular jet nebulizer again here. Particle size was smaller. Um, Only 0.8% of the drug was delivered to the urine. So basically, it only processed this much versus 5.6%. So considerably higher amount, still a low amount, but a considerably higher amount made it through the body and into the kidneys to be excreted than the IPV device. So again, not a commentary on the device itself as it's used for lung expansion and bronchial hygiene, but just maybe a question about whether it's the best way to deliver the aerosol that the patient may need in conjunction with their bronchial hygiene. This was done by a couple of my colleagues, Dr. Fink, Dr. Lee, and Dr. El Shafei here at Rush University Medical Center. This was done in 2020. It was a bench study that compared different placements and different delivery of medication using a jet nebulizer, the Metaneb nebulizer device, which I get is not the IPV, but it is the high frequency therapy. And then also a vibrating mesh nebulizer. And what they found was that the lowest particle deposition to the lung in the way that they tracked it, the lowest particle deposition was through the Metaneb device, less than 2%. Or around 2%, sorry, of the medication, 2.58 and 2.58%. And then the highest delivery was with the vibrating mesh neb, placed between the mask and the manifold, and that was about 12.5% of the drug. So again, sort of supporting this idea that maybe aerosol delivery through the high frequency therapy may not be the ideal route of administration for medication. So now we've kind of hit on this a little bit from a high level, but how do we choose patients? Because we saw some evidence as I went through those papers, we saw some evidence that stated that routine use of bronchial hygiene and airway clearance therapy may not be recommended, but that doesn't mean it's not useful in certain patient populations. So let's dig into that a little bit here. So speaking specifically of the IPV device, which is one that we've again incorporated into our practice here in a higher way. We've talked about cystic fibrosis and bronchiectasis. Those are about as close to slam dunk as we have in this bronchial hygiene universe. But then mucus plugging might be another disease process that we really look at closely, especially as it pertains to the IPV, because of the high velocity therapy and the way that we can get through and behind these secretions in a way that we can't with some of the other with the external chest wall oscillation and the oscillatory therapies that exist in the other realms. And then neuromuscular disease, again, some of these diseases, depending on which one that you're talking about, this is a big umbrella that encompasses a lot of different disorders. But some of these neuromuscular diseases that hyperproduce secretions and or blunt cough effort because of weakness and things like that, there's probably a place, especially if you look at both the lung expansion and the bronchial hygiene piece that we can have with the IPV. So what are some other situations, though? These are the ones that seem like they make a lot of sense and have some data to support, but what else could we think about? So I want to do this in the form of some cases, and I want to think about some of these patients that we're going to look at. So in this first case, we have a 46-year-old male presented with no significant past medical history, which is not that uncommon. Some younger people don't go to the doctor. And then had some reason to suspect pneumonia with this person that came in. So vitals were heart rate 116, respiratory rate a little on the high side at 24. And when we assessed the patient, they were saturating at 93% on a 4-liter cannula. Blood pressure was fine. Some of the pertinent labs that were there by the time we got there, elevated white blood cell count pretty considerably at 31,000. along with a borderline pH, a little bit elevated CO2. Nothing that I would have been scared about or any of that. And a PO2 that's kind of trending a bit on the low side. This is what we knew when we came in, and this was the chest X-ray that we saw. Kind of supports what we talked about. We see a pretty significant right lower lobe infiltrate here, along with the white blood cell count and the other symptoms. Pretty easy jump to pneumonia with that patient. So I kind of want to know from the group, if you had this patient come into your ER, let's say, and that's what you knew, what would you do? Should we do bronchial hygiene? If we did, how do we select our therapy? And what would the goals of the therapy be with that patient? So give everybody a minute to answer. I'm just curious what the practice would be at other facilities, and then I'll tell you kind of what we did. And some of this is obviously going to be based on the options that you have, right? I mean, if you don't have one of these options, then, obviously that's not going to be one of your choices. So, so that's going to weigh into this as well. Okay. All right. Okay. So, patient is not indicated, about 11%. And we had about 250 respondents. That's great. Manual CPT, maybe. Vest therapy, again, depending on what you have available. Cough assist is interesting, 5%. PEP therapy, a lot of people said PEP therapy. And then, down at the bottom there, a total of 34% of you said some version of interpulmonary percussive ventilation, either OLE or IPV. Some of that may be what you have available at your facility. So I can tell you with this patient, did not sound bad initially, did not sound like there were a lot of secretions, but based on the x-ray and based on the way the patient was coughing, we thought, you know what, once we get him upstairs to the ICU, let's do IPV on him, and just with the goal, let's see if anything loosens up. And sure enough, after I believe 3 therapies, so we did it every 4, so by the end of the first shift, we were getting a considerable amount of secretions coughed up from this person who was able to cough pretty well on their own. They just weren't coughing anything up, and nothing was loose enough to necessarily hear it. So in this case, our goal was, let's try something for a set period of time and just see if there's anything to what we're seeing on the x-ray that we can get out. If we can't, or if it's not making a difference, we'll just simply stop doing it. So I think there's some value here in if there's some evidence that the patient has secretions, in this case, the chest x-ray we saw, then maybe the reason they're not coughing them up is because they're very congealed, they're very packed into a certain area of the lung and not able to be coughed up. So if we can help with that, then there may be some value in that patient. So in this case, it did. In this case, we were able to help that patient cough up some secretions. We were able to wean their oxygen off by the next shift, and they continued through their course. This was also in combination with, because this patient was fairly able to move around, being 46 years old and relatively healthy up to that point, was able to get up and walk around their room and different things like that. So I'm sure that was also a consideration. But I'm confident that in that case, the administration of IPV certainly sped things along and got this patient out of the hospital in about 48 hours, which may have been sooner than what we would have been able to get them out before we considered that. Case 2, this is a 52-year-old male. This patient had been to the doctor. History of morbid obesity. Again, we're seeing this a lot more, at least in my facility, and I just think in general. Hypertension typically go hand in hand, and then type 2 diabetes. This is not this isn't a mystery. Heart rate a little bit on the high side. Again, a little bit elevated respiratory rate. This patient a little bit worse oxygenation at 92% on 6 liters. Probably multiple things happening here with the compression atelectasis that we talked about earlier. upon auscultation, this patient did have a bit of a rumbly cough as well as some coarse crackles that we were able to auscultate with our stethoscope. This was that patient's X-ray. Now, the interesting thing about this patient, as you see here, the interesting thing here was this patient pretty clearly had evidence of fluid overload. We have some small pleural effusions here, much smaller one here, but a little bit bigger one on this side, and then some evidence of pulmonary edema throughout the lung fields. Now, obviously, I hope that we've all learned by now that bronchial hygiene for fluid overload is not really indicated. But the question becomes, if we're hearing what could be secretions, we have a lot of stuff going on here. Could there be some secretions, buried under here? And again, just sort of spitballing because this patient was a bit compromised and things like that. So again, I asked the question based on what we know here, should we do bronchial hygiene on this patient? Pretty solid evidence of fluid overload. Could probably explain a lot of what we talked about with the symptoms, could probably explain a lot of just the fluid overload. But if we consider bronchial hygiene, what would our goals be and what options do we have? Same options, obviously, is the last question. And whatever each of you have available at your facilities, but what is the move here? Patient clearly compromised by needing 6 liters to saturate 92%. Obviously, that X-ray is pretty abnormal. So what do we think? Okay. Okay. A lot of you, 19% out of the 271 votes that we got, 19% think that the patient's not indicated. Manual CPT, small amount, vest, cough assist, and then, again, we've got 40, what do we got? 47%, some form of inner pulmonary percussive ventilation. So turns out, again, we had the goal in mind, let's do a therapy or two and see if there's any secretions in there hiding. It turned out in this case, again, patient did have some secretions to cough up. We were able to significantly get some secretions out of this patient. Of course, we were also diuresing because the fluid overload's pretty obvious. We were also diuresing, but I think the combination of the two, again, sped up this patient's recovery because there were some secretions that we were able to get out as a result of this, because the patient wasn't coughing anything up. We did hear some congestion when the patient tried to cough, but nothing was moving in any sort of meaningful way at that point. So interesting. Last case I have, 64-year-old male with a COPD history along with hypertension, hyperlipidemia, heart rate 91, a little bit higher respiratory rate than these other two. This is 28. This is a bit more concerning. This patient, very hypoxemic, 95% on a 15-liter non-rebreather. Blood pressure, again, fine. Coarse crackles and congested cough. And here was our patient's X-ray. So you can see here, COPD, we get the flattened diaphragms, borderline hyperexpanded here. And then we have an infiltrate here on the right side, along with some scattered infiltrates throughout the right lung field. And then the left lung field, you can see, is completely collapsed from about mid-lung on down. As a result, and you can almost see as the airway comes down, you can almost see where the airway goes away here from the presumed mucus plug. Also, probably a pleural effusion underlying as well, but suspected mucus plugging. Very high suspicion here of mucus plugging. So, last question again. What do we do here? Do we do bronchial hygiene? If so, what are the goals and what are our options? Again, same question. Or do we just immediately intubate and bronch this patient? What are our options here? This patient's on a lot of oxygen. This patient's already breathing 28, presumably because he only has probably 2/3 of one lung operating here. So just curious what everyone would do here. Okay. All right. A lot more on the inner pulmonary percussive ventilation on this particular patient. We're at 78% of almost 300 respondents would put this patient on some form of inner pulmonary percussive ventilation that they have available. I'm presuming that the people that didn't think it was indicated are probably because they would just bronch this patient. That was certainly discussed. It turned out this patient was identified here at about 11 o'clock at night. And at my facility and maybe some others, we don't do a lot of bronchs at 11 o'clock at night. So it turned out we were able to use inner pulmonary percussive ventilation with the IPV device, and we were able to open this patient's lung up considerably throughout the night. We were able to wean some of the oxygen by morning. This patient did end up getting a bronchoscopy for diagnosis as well as to clear out the remainder of the secretions, but we were able to gain on the secretions quite a bit, and we were able to get this patient off of the extreme amounts of oxygen that they were on and get their respiratory rate down and get them safely through the shift to the point where they could do the bronchoscopy much more safely. So we did have an advantage, even if it wasn't to fully turn that patient around. So I'm going to conclude here. We have a lot of choices. We went over many of them earlier in the talk. We have many choices to deliver bronchial hygiene. We have some disease processes that are more likely to benefit based on the data that we have, at least. I think careful selection of patients outside of these groups is kind of where we should focus in our practice. And I think we should be very goal-oriented in what we want to do with this, and have an end goal in mind, and also have some parameters in mind to determine if this is successful or a waste of the therapist's time. IPV in particular offers a lot of flexibility and provides benefits in multiple ways, from the pressure that is provided to reverse atelectasis, along with the secretion clearance component. Retained secretions and mucus plugging are good targets. So if you have reason to suspect that in your patients, those are probably a good place to start. Again, my advice, have some goals in mind. What do I want to accomplish? What is going to deem this successful? And if I don't see that, at what point am I going to say, okay, maybe this wasn't the right patient, or maybe there wasn't a benefit here? Finally, I would say, and I know if you go to a lot of talks, you hear this a lot, that more research is needed. I think that is the case, though, in many of those cases. And I think here as well, you saw from the clinical practice guidelines that we really only have low-level evidence. I don't know where the best focus is for future research, just off the top of my head, but I can tell you that I think, as with anything, if we had more robust research and more high-level research, it would just make things make a lot more sense for us. And so however that happens, I think that would be a benefit here as well as in a lot of other areas. So I'm going to stop here, and I am happy to take some questions if anybody has any.
Great. Thank you, Andy, for that presentation. While people are getting their questions, I think we'll have time for just a couple. Just a reminder that once you finish this webinar, you'll be redirected to a page where you complete the evaluation form. Again, this is how you get your CE certificate. So please be sure to fill out that form after you leave the webinar. So then, Andy, do you want to go to the next slide? I have maybe a couple questions that we can get to.
Okay.
So you talked a lot about the clinical practice guidelines and how ACT is not necessarily recommended for routine postoperative care. Can you expand a little further on, I mean, do you use it on your unit in postoperative care? This person asking, they use it a lot on their post-CABG patients, for example.
Well, I think I'll get back to my statement from a minute ago, in that if I think that I have a goal in mind for that patient, so if I see evidence of atelectasis, which you often do in the post-op population, then sure, that would be something I would certainly consider. I think that where we get lost in the weeds a bit with that is just simply being a post-op patient is reason enough for many people to recommend and order bronchial hygiene therapy. And I think, as the guidelines showed, the routine use of any sort of airway clearance or lung expansion is not necessarily recommended. But if there's evidence of atelectasis and things that could by themselves benefit from those therapies, I think we should look specifically at those patients and sort of use our resources on those patients instead of getting lost in the weeds on a patient that's not going to benefit, and then maybe we aren't spending the right amount of time with some of our other patients. I think that's where
Sure.
the divergence is.
Okay, great. Maybe one more now that we're at the top of the hour, we can close it out with this one. Do you see patients that get early intervention with IPV have shorter hospital stays compared to those that get it maybe a little bit later in their course?
That's a great question. And I think with any therapy, early intervention is always better. I think the quicker you can identify a patient as being a potential to benefit, the better off you'll be. Sometimes in the ER, you see the evidence of that, sometimes not till they get to the ICU, sometimes later in the shift. I think the earlier you intervene, the better, no matter what therapy you're talking about. And this would be no exception, because I think that, you can, before that atelectasis gets to the point where some of those alveoli are less recruitable, if that's what you're using it for, or before those secretions get to the point where they're much harder to move, you're going to get a lot more benefit for sure. But the clinical reality is sometimes we don't see these patients till a bit later in their course, or we don't get called to the bedside, or maybe the patient doesn't develop symptoms that make us want to get a chest x-ray or things like that until a bit later. So I think you intervene as early as you can, but if you have some evidence to intervene earlier, I think it's a good idea. Yeah.
Great, thank you. So I
Of
know
course.
there are a lot of questions out there, but we will follow up with all of you. Andy will help us out with that so he can give his experience as well. I just want to be respectful of everyone's time. So with that, I will say thank you to Andy for this great presentation, and thank you all for your participation. It's really interesting to see your answers, see how you would take care of these patients. So thank
Yes.
you as well.
And my contact information for everyone is on this slide. I've left it up. Please feel free to text, email, whatever. I'm happy to help in any way that I can. And I just wanted to reiterate one more time that I don't really necessarily have a preference. We use many of the pieces of equipment that were mentioned in this talk at my hospital. I've used the rest of it at some point in my career. There's pros and cons, as I mentioned, to all of them, and I don't necessarily have a preference. It's just depending on the patient that I see.
Great. Thank you so much, Andy.
Thank you all.